Good morning, good afternoon, and welcome everyone to today's webinar, A Divine Intervention to Reduce Black-White Disparities in End-Stage Cancer Care with Dr. Holly Prigerson and Reverend Carla Price. I'm Andrew Andresco, Project Coordinator for Transforming Chaplaincy, and we are delighted you could all join us. Just some housekeeping instructions off the top. You are listening in using your computer's speaker system by default and are muted. Should you have any technical questions regarding audio or visual, please type those into the chat box located in the platform's dashboard. You will have the opportunity to submit text questions by typing your questions into the questions pane of the control panel. You may send in your questions at any time. During the presentation, we will collect these and hope to address as many as we can during the Q&A at the end of today's presentation. With that, I'd like to introduce Paul Galchut, convener of Transforming Chaplaincy's Hospice and Palliative Care Spiritual Care Network and research chaplain with M Fairview Health. Paul?
Thank you, Andy. Appreciate all the work that you do to make this happen, and a huge echo of a welcome to you, Carla and Holly, Dr. Prigerson, and Reverend Price. I'm going to offer some introductions for our presenter and our respondent today, and are so grateful for the gift of their time, their expertise, and what they bring to all of us who get to work in this field. So Dr. Holly Prigerson is the Irving Sherwood Wright Professor of Geriatrics at the Weill Cornell School of Medicine and the Director at the Cornell Center for Research on End-of-Life Care. Dr. Prigerson was approved for tenure at Yale, Harvard, and Weill Cornell Medicine, and served as the principal investigator on numerous NIH, National Institutes for Health investigations, including studies that justify the inclusion of prolonged grief disorder with the International Classification of Diseases and the Diagnostic Statistical Manual 5th version text revision, which have examined psychosocial influences on and outcomes of end-of-life care. She received the Harvard Medical School's Clifford Barger Excellence in Mentoring Award, the 2012 National Hospice and Palliative Care Organization's Distinguished Researcher Award, and the National Cancer Institute's R35 Outstanding Investigator Award, and the 2018 American Association of Hospice and Palliative Medicine Award for Excellence in Scientific Research. And I'm guessing, Holly, those are the Cliff Note versions of it, so thank you for sharing that. The Reverend Price is the manager for pastoral care at the University of Texas Medical Branch in Galveston, Texas. You're a far ways from me here up here in Minneapolis, where it's below freezing. She's an ordained elder in the United Methodist Church, credentialed as a board-certified chaplain through the Association of Professional Chaplains. She's also a certified education candidate with the Association of Clinical Pastoral Education. She has extensive experience as a senior hospital chaplain with a diverse multicultural patient population in both the medical center as well as the community healthcare setting for inpatient and outpatient environments for family members and for staff. She uses a variety of spiritual and psychosocial skills to assess spiritual needs, to develop appropriate spiritual care interventions and plans while demonstrating experience and expertise to provide spiritual and pastoral care. And Carla, it's been a pleasure getting to know you a little bit as well, especially, it's not on your bio, but I appreciate having the chance to connect with you about your expertise in healthcare while serving in the military as a healthcare administrator. So I appreciate that lens and experience that you bring. So without further ado, Dr. Prigerson, Holly, it's such a pleasure to have you be among us, and thank you for saying yes to this presentation. I look forward to seeing you on the back end of it.
Okay, thank you for that introduction, Paul. Let me try to get the presentation going. Share the screen. Okay, so I'll be talking today about a proposal, what we call our divine intervention. And it's a divine intervention to reduce Black-white disparities in end-stage cancer care. I have a few issues that I'd like to highlight both throughout the talk, and also I hope this is really a conversation. I really appreciate the opportunity to talk with chaplains and people interested in this topic, because we're trying to develop the evidence base to highlight and demonstrate the impact and the positive impact and a variety of outcomes that I'll be discussing in a moment, but also try to understand further how to best study these things, and also how to understand what the mechanisms, assuming that we do continue to demonstrate positive effects, why do healthcare chaplains improve outcomes? So this talk seeks to make the case that healthcare chaplaincy has unrealized potential to address unmet spiritual care needs of patients who are approaching death. And we also think it can improve end-of-life cancer care in particular, but probably beyond just cancer, but we focus on cancer patient populations. We also want to explore what we think is the promise of healthcare chaplaincy to reduce Black-white disparities in the quality of end-stage cancer care. So what are the problems with end-of-life care that healthcare chaplains might be able to address? As recently as last week, in a JAMA 2021 publication by Dr. Wang, they were referring to high rates of chemotherapy within 2 weeks of death, emergency department visits within a month or less, the last few weeks of death, hospitalizations, frequent intensive care use, care unit use, and infrequent hospice enrollment and high rates of disenrollment when patients do enroll in hospice. So there have been numerous studies, and I'll be presenting data on some of them that show the high rates of intensive care unit use in the last month of life, that people are dying more frequently than you might expect in the ICU. And COVID's made this issue a growing concern, not a lessening concern. So for example, a year ago, it was shocking to think that COVID was the number 3 cause of death. As in 2021, it's gone to about 750,000 cases, making it the leading cause of death, beating out heart disease and cancer. And why is that important? It's because people are dying more in intensive care units as a result of COVID. So what is it about aggressive, intensive end-of-life care that makes it worse care? So I think as a general rule, the more things done to someone as they're dying, being resuscitated, ventilated, feeding tubes, ICU stays, all those things are inversely associated with the quality of life or quality of death of a patient. So the more done, the worse someone feels. My brother-in-law is a retired cardiologist, and he had a kind of cute way of putting it. He'd say, when the tube to orifice ratio is high, your quality of life is low. So the more poking and prodding and tubes is impairing your quality of life. So an example of that is intubation. Many people don't realize that when people are intubated or they have a tube stuck in their throat to help them breathe, that they can't talk, they can't eat, they're usually unconscious and usually sedated to enable your throat to relax to have a vent. And they're unlikely to survive the receipt of being ventilated, and they're unlikely to survive that hospital stay. So it's really very questionable why someone who's dying would be intubated. There are a variety of other problems that also end-of-life care, healthcare chaplains might be able to address with end-of-life care. So what are some of those problems? One is a lack of peaceful acceptance of someone's impending death. The other is a lack of prognostic awareness, a denial that death is close. As I referred to just before, late hospice referrals, usually about almost half of hospice referrals are within days of someone's death, usually really hamstringing the ability of hospice services to address the needs and make patients comfortable, because they're usually actively dying and then just referred immediately to hospice at the very, very end when it's too late. High rates of unmet need for palliation of dyspnea, breathlessness, and anxiety and depression. Poor pain management, which has only been exacerbated by the opioid epidemic, where a lot of clinicians, including oncologists, are more and more reluctant to prescribe needed opioid use for fear of addiction, which makes very little sense for someone who's dying. Low rates of engagement in advanced care planning, low rates of do not resuscitate order completion, and low rates of end-of-life discussions occurring with oncologists. Patients are not getting what we call value concordant care. For example, dying alone on burdensome machines in the hospital, despite a preference for dying comfortably at home surrounded by family, and conversely, wanting to die, getting everything possible, but being denied what they wanted. So it works both ways. We're not saying what patients should want, but we are saying that they should have informed choices and care should be aligned with those informed choices. There are also stark racial disparities in advanced care planning and in end-of-life care. And last but not least is unmet spiritual care needs of dying patients. So research has shown that dying patients seek hope, meaning, and comfort from religion and spirituality. Data suggests that they've shown that 88% of advanced cancer patients report that religious and spiritual needs are at least somewhat important to them. Yet most, about 72%, have reported that their religious and spiritual care needs have not been met by the care team, for example, their oncologists. Support of religious and spiritual care needs may prove especially beneficial to those who are religious, including Black patients who often rely heavily on religion to cope with cancer. So what are the problems that healthcare chaplains may be able to address to reduce disparities in end-of-life care? The data show that compared to white patients, Black patients are more likely to die in an ICU than their white counterparts. So they're more likely to be resuscitated in the hospital and die following resuscitation. They're less likely to enroll and more likely to disenroll from hospice than their white counterparts. They're less likely to acknowledge being terminally ill, to engage in advanced care planning, and one second, oops, let me just move that, and to rely on religious beliefs so when we ask patients what is the basis of their prognostic understanding, there are racial disparities in trusted medical information, and the quote, "God, not my doctors, will decide when my time has come," reflects that basis of prognostic understanding that is racially disparate. So what's the data? What are the data that support that there are these disparities? And a study of almost 500,000 Medicare beneficiaries in California about 20 years ago. The data are getting old, but it still makes the point that compared to whites, African Americans, Latino immigrants, Latino native patients, and Asian immigrant patients, they're had the highest rates of dying as an inpatient compared to their white counterparts. So underrepresented minority groups are dying at higher rates, getting more and more aggressive care at the end of life. Similarly, a New England Journal of Medicine publication in 2009 showed Black patients were more likely to receive CPR than their white counterparts in that hospital stay, and they were 30% more likely to die following being resuscitated. So I'll be presenting data from our own study, the Coping with Cancer study, and I thought it would be helpful to provide a brief overview so you understand where our data are coming from. So our Coping with Cancer RR1s were what they call longitudinal prospective cohort studies. So we got patients with terminal prognosis, so they had advanced metastatic cancers that had progressed on at least one line of chemotherapy and whom their oncologists thought were terminally ill, would have less than 6 months left to live. They were recruited from one of 8 outpatient cancer clinics across the country, including at Yale, Memorial Sloan Kettering, University of Texas Southwestern, and the Dana-Farber Cancer Institute. And what we did is we identified these advanced cancer patients. For some of these RR1s, a caregiver was required to participate, but for some of them it wasn't required. But for the first one, we had patients and caregivers about a median of 4 to 5 months before they died. And then after they died, we looked at their medical chart to see the type of care that they received in the last month. And we also, within a month of the death, interviewed the family caregivers and or their nurses, for example, a hospice nurse, to find out how things went in the very last month of the patient's life. And we had a basic conceptual model which said that end-of-life discussions are likely to impact a lot of important, what we think are important clinical care outcomes, such as the receipt of intensive life-prolonging care versus hospice care, or receipt of what we call gold concordant or value concordant care. And we thought that those outcomes would be mediated by what we call or refer to as communication goals. And those goals would be things like terminal illness awareness or prognostic understanding, treatment preferences for aggressive care or comfort care, and advanced care planning. That the reasons why end-of-life discussions might translate into differences in care received is because patients would be more likely to understand what their prognosis was, that their treatment preferences might be different or based on a knowledge of what the risks and benefits of different treatment options were, and by engaging in advanced care planning to understand and unpack what it is they would want. So our data showed, this is probably one of our most well-cited reports, was that end-of-life, I had gone to a few palliative care meetings and oncology meetings, and what I was hearing was that oncologists really didn't want to engage in end-of-life discussions because they didn't see the point. Why make patients needlessly hopeless if there's really no benefit to it? So what we undertook to do was to look at what are the effects of engaging in an end-of-life discussion on those outcomes that I just showed you. So what we did demonstrate was that even when we propensity weighted away the differences between people who were likely to engage in an end-of-life discussion and those who were not, to make it and try to isolate the effect of an end-of-life discussion over, for example, being married is associated with greater likelihood of engaging in an end-of-life discussion. So we tried to neutralize those confounders and try to isolate the effects in this prospective longitudinal cohort study to say, what are the effects of this discussion on those outcomes? And we found that it didn't make patients significantly more depressed or hopeless or anxious, none of those psychological outcomes, but it was associated with greater acceptance of being terminally ill, more realistic life expectancy estimates, a preference for comfort over aggressive life prolonging care, a higher completion rate of do not resuscitate orders, and a lower receipt of non-curative, very burdensome intensive care. So end-of-life discussions in that paper, the reason why it resonated and it was used in these death panel discussions to justify why should Medicare sponsor an end-of-life discussion. So we were very, pleased with ourselves, and we'd shown something, and it was in an open letter to Obama saying, look, there's evidence to support. So that's another reason why I'm here. The evidence is very persuasive and powerful if you can show these things and that there are effects. So that's what we would like to do similarly for the effects of healthcare chaplaincy. But that analysis that we did that showed all these wonderful benefits of an end-of-life discussion, we found it was modified significantly by race and by religious beliefs in healthcare chaplain visits. So, for example, we found a significant interaction. What this means is that there's a hugely different effect of end-of-life discussions on whether you acknowledge being terminally ill, if the patient was Black compared to if the patient was white. And so here are the data that lead to the conclusion that there's a problem with communication with Black patients from their oncologist. We found that end-of-life discussions with an oncologist for white patients significantly reduced the effect of receiving intensive end-of-life care. And this is our gold concordant care outcome, that they got the care that they indicated and would have been consistent with their preferences. None of these effects of those end-of-life discussions on those outcomes were significant for the Black patients. So there's something not working with based on race. We did another analysis when we asked these advanced cancer patients to offer what their life expectancy estimate was, and they did, and they were wildly overly optimistic, but regardless of race. But one of the things that we found was when we asked, so what's the source of, what do you base that estimate on, we found dramatically different answers based on race. So if you look on the left pie chart, you see there's 21% said it was some medical professional. If you look on the right, 0%, zero. You can't get lower or worse than that. 0% of blue, because no Black patient in our sample based their life expectancy estimate on anything communicated or discussed with a healthcare professional. It should be noted that both whites and Blacks largely based their life expectancy estimate on their own personal belief, regardless of what their doctor said. But what was also dramatically different was for the white patients, only 2% said it was based on a religious belief, but 35% of the Black patients said their life expectancy estimate was based on their religious belief, that it's really more of a conversation between them and God than between them and doctors. So all right, so religious beliefs are really seemingly important in this patient population. And we've shown that these beliefs are dramatically influencing end-of-life care. So we worked with Tracy Balboni, a radiation oncologist at Dana-Farber, and we developed this is actually a fairly recent scale that we developed in response to this work, and what we call the RBEC, the Religious Beliefs About End-of-Life, largely cancer care scale items. And the items include things like, please bear with me, I will read them all because I think it's important for the audience to react to them and provide feedback on what they, if any sort of thoughts they have about these items. My belief in God relieves me of needing to think about future medical decisions. For example, do not resuscitate orders or signing a healthcare proxy, especially near the end of life. I will accept every possible medical treatment because my faith tells me to do everything I can to stay alive longer. I think agreeing to a do not resuscitate order is immoral because of my religious beliefs. I would be giving up on my faith if I stopped pursuing cancer treatment. I believe that God could perform a miracle in curing me of cancer. And this is an item we've singled out, and I'll be showing why soon. This belief in miracles is extremely important for cancer patient decision-making at the end of life. Enduring painful medical procedures because of suffering is part of God testing my faith. And it helps enduring the suffering that comes with difficult medical procedures is on the basis of my religious beliefs. So this analysis, I realize it's going to be hard to sort of get to the punchline and understand what all these numbers mean. The basic idea here was we were looking at the effects of end-of-life discussions. Here it was on prognostic understanding, because as I said, there are significant differences in prognostic understanding by race, but also by religious beliefs. And what we found is that those who had a strong belief in miracles, the effect of end-of-life discussions on a correct understanding of their life expectancy wasn't found. And for those who had a weak belief in miracles, the end-of-life discussion significantly affected their accurate understanding of their prognosis. So what this demonstrates is that a belief in miracles is affecting someone's willingness to basically buy what their doctors are selling, to basically believe and base their understanding of how long they have left to live on what their doctors say. If you have a very strong belief in miracles, that seems to interact with the end-of-life discussions in terms of its impact on your prognostic understanding. So this reduces to miracles are really important to understand in the mix. And we did an analysis a while ago showing spiritual support. This was in the Copeland Cancer Study. We divided spiritual support from the medical community based on a question that was, to what extent are your religious and spiritual needs being supported by the medical team, by doctors, nurses, and the hospital chaplain. So this is a measure of spiritual support from the medical community, and we divided it into low and high support. And we found extremely dramatic differences based on whether the advanced cancer patient said they had high spiritual support from the healthcare team or low spiritual support from the healthcare team. So in the total sample, you can see that those with low spiritual support had much higher rates of intensive care use at the end of life, and those with high had much lower rates of intensive care use admission in the last month of life. And the same for ICU deaths. Low spiritual support from the healthcare team, higher rates of dying in the ICU, high spiritual support, very low rates of dying in the ICU. When we looked at, so that was the full sample. When we divided by racial and ethnic minorities, white versus mostly it was Blacks and Latinos in our study. Huge differences, those same differences held, so that low receipt of spiritual support, very high frequency of intensive care use and aggressive care at the end of life. High spiritual support, ICU admissions were low. Same for ICU deaths. And then we sorted it by whether they were high on religious coping. And so obviously these groups overlap largely, but for that subgroup that indicated that religion really mattered a lot to them, their religious beliefs were extremely important to their cancer care, we found that those who said that they were supported had very low rates of ICU admissions in the last month of life and very almost negligible effect on negligible rates of ICU death. And the converse was true for hospice. So those who were very supported by their healthcare chaplain, 73% in the full sample, 73% compared to 53% who had low spiritual support. So hospice, saying that they were supported by a healthcare chaplain or the medical team supported their religious and spiritual beliefs, significantly increased the likelihood of hospice enrollment in this is in the full sample, in minorities, and in the very religious groups. In all those, the same trends apply. So in the Coping with Cancer data, we've also shown that having that a healthcare chaplain visit saying that they have been supported and visited by a healthcare chaplain was significantly associated with the patient's report of peaceful acceptance of their terminal illness. And peaceful acceptance of the terminal illness was associated with higher rates of willingness to talk about and engage in advanced care planning. Advanced care planning, we've shown, and others have shown repeatedly, that that's associated with better quality of life and receipt of value concordant care. For example, desired intensive or palliative care, what informed choices are met. So, we're having all these data, and I still have a few more examples of healthcare chaplains being helpful for advanced cancer patients. So we've shown that patients who were visited by a healthcare chaplain reported fewer unmet spiritual care needs, which were actually very high. We did a parallel Coping with Cancer study in Soweto in South Africa. And in many respects, that analysis is the most remarkable. Those are the most remarkable findings of all, because they were all advanced cancer patients, largely lung cancer and breast cancer patients, in Chris Baragwanath Hospital in Soweto. And they were all palliative care patients. So this was not the effect of palliative care. They were all had palliative care. It was only the patients who said that they were visited by a spiritual a pastor or a spiritual counselor. And there was a significant reduction between baseline and the follow-up assessments in their physical pain reported, fewer use of opioids, their family members reported worrying less, and they were significantly more likely to die in their preferred location, be it either at home or in the hospital. And lastly, in preliminary analyses, we've tried to understand how would a visit by a healthcare chaplain with the advanced cancer patients differ with respect to advanced care planning for our Black and white patients. And what we found is that patients who said that they had seen a healthcare chaplain who were Black were almost 5 times more likely to engage in a do not resuscitate, to have a do not resuscitate order on record compared to those who were not visited by a healthcare chaplain. For white patients, it worked through they were about 2.5 times more likely to engage in an end-of-life discussion with their oncologist compared to not. But the basic take-home was it's helpful for both these patient populations, but there appear to be differences in why and how healthcare chaplains affect end-of-life care and care planning. There seem to be different mechanisms. So this is what's led us to where we are and why we're here right now. And we've proposed a few different studies, what we call our divine intervention studies. The goal is to try to understand, I think Paul had asked why I'm interested in this topic and what we hope to demonstrate. And the answer is we have all this data and all these results that are really pointing to how important religion and spiritual care and healthcare chaplains might be in the context of end-of-life care. And we have a few hypotheses, but we want to confirm that it's true. We also want to propose, as people have done for palliative care, that rather than healthcare chaplains in the hospital as the patient's dying with last rites, rather, if healthcare chaplains are so helpful, we should have early integration of chaplaincy into outpatient oncology clinics to address spiritual care needs before it becomes a crisis and people are dying in the hospital. So we think that there needs to be greater recognition of the potential. We want to demonstrate what are the effects of healthcare chaplains on advanced care planning and how does it differ by race. And then we want to understand, assuming that we will show that there are benefits, we want to understand the mechanisms. Why is it the case that healthcare chaplains are resulting in these better outcomes that I've just mentioned? And we've proposed race-specific models, which initially even I, as we were proposing them, it felt like segregation, to be honest. It felt like it seems almost counterintuitive because separate isn't equal. But then the more we started studying it, it seemed like there are different underlying mechanisms and outcomes, and to blur it, like for example, with our end-of-life discussion paper, where we found that there were these big effects on end-of-life discussions on these outcomes, but not when we drilled down and started looking more granularly at different racial groups. That's when we discovered, well, no, there's still a problem with end-of-life discussions with certain patient populations. So aside from determining, having the evidence base to demonstrate that early integration of healthcare chaplaincy into advanced cancer care might improve some of the end-of-life care and improve the quality of life and quality of death, and possibly even the bereavement adjustment of the surviving family members. We also want to understand better these race-specific models of why chaplains might affect things differently. So we've proposed an observational study to try to understand the outcomes, demonstrate them, and then understand the different mechanisms if those same findings reemerge. We also need pilot data to start to show feasibility and acceptability. So we also just recently proposed an R21 that proposes the early integration of chaplains into an outpatient oncology setting. And that's one of the reasons why I know Reverend Price is she's helping us think through how to implement these studies in a hospital, in a cancer setting, And we want to see, is it going to be acceptable to chaplains to be integrated inside an outpatient cancer setting? Is it going to be acceptable to cancer patients, their family members, and to oncology care providers? So that's really a feasibility study, and we need to show that it's feasible, that it will be acceptable to all these different partners. And then we'll try to examine preliminary efficacy by comparing meeting with a healthcare chaplain, not telling them what to do, but just trying to understand better and examine the impact of what's done, and compare that to intercessory prayer, which seems like what we call an attention control condition. So we want to do all those things. The last two points I want to make are our race-specific models hypothesize the following. So we read W.E.B. Du Bois, his treatise on the soul of Black people, and he describes this sense of double consciousness and a need to lift the veil so that patients, regardless of their race, feel that their healthcare providers see them as and respect them and their humanity, and that there's trust and that a therapeutic alliance is built. And we think that one of the mechanisms, the reasons why we found that meeting with a chaplain increases the rates of DNR order completion among Black patients who tend not to want to sign off on a DNR, which is totally understandable in light of the medical abuses that have been committed against Black people. So what do chaplains bring to the table? We think that they are able to, in this setting of an outpatient cancer clinic, I think there should be no conflict of interest. There's no other agenda, and that a healthcare chaplain, we hypothesize, will help a patient in that context feel seen, respected, and heard, which should promote peaceful acceptance and prognostic understanding regardless of race. But we think the key issue for Black patients is it probably that healthcare chaplains may enhance and reduce medical mistrust in the system, which would make any person reluctant to sign a do not resuscitate order in that context. For the white patients, our model is that meeting with a healthcare chaplain similarly helps patients who might be talking to their oncologist about the next line of chemo, or things that they think need to be might offer some hope. We think that talking with a healthcare chaplain will enable patients, regardless of race, to recognize that they have some existential concerns, some unmet spiritual care needs, and that meeting with a chaplain will enhance peaceful acceptance of death and their prognostic understanding. And that will create an environment of psychological readiness to support having an end-of-life discussion, whereas those who have not met with a healthcare chaplain might be more reluctant to do so and still be more in the let's try the next line of chemo instead. So in conclusion, this is why I'm here. I think that healthcare chaplaincy has unrealized potential to address unmet spiritual care needs of patients who are getting close to death. I think it might also improve end-of-life care that these patients receive. Healthcare chaplaincy may also offer the potential to reduce the very dramatic Black-white disparities in the quality of end-stage cancer care. We are trying to develop both an observational study to demonstrate impact, as well as try to unearth and examine and discover underlying mechanisms, and a small pilot to test our ability, the feasibility and acceptability and preliminary efficacy of integrating a healthcare chaplain in outpatient oncology settings to see whether it can improve addressing unmet spiritual care needs, improve end-of-life care received, and potentially reduce disparities in the quality of end-stage cancer care. So I'll end it there, but I'm very eager to hear your thoughts, feelings, and reactions, and I'll stop I'll stop now.
Dr. Ferguson, many thanks. When I saw these slides in advance, I was wondering how anybody could masterfully get through this with such efficiency and to do it so thoroughly. And you did it. I just had to say, I went to PubMed, yesterday. I think just like, how many studies that you've, just on PubMed as that database alone. I mean, it was like watching like the Yodeler on The Price is Right. I mean, the steep kind of curve of the histograph that like shows the investment that you've done in research, the people that you've mentored. We so appreciate your time and what you've contributed here, and look forward to your response, Reverend Price. For those of you, before I turn it over to Carla, if you have any questions, please submit those. We will do our best to get to as many questions as possible for Dr. Pregerson and Reverend Price. So Carla, without further ado, thank you again, Holly.
You're welcome.
So thank you, Paul. Thank you, Andy, and thank you, Holly. My response is that thank you for affirming, I believe, the work that we do. I am so excited about the work as chaplaincy, the fact that we get to journey with individuals at the end of life in their spiritual well-being, with their spiritual well-being and their spiritual care. And for me, it's an honor to do so. But I also recognize that with the shrinking dollars with healthcare, we as chaplains, this is where Paul and Andy are so vital and important, but this is why we as chaplains have to really speak to the outcomes that we can help offer that interdisciplinary team, that clinical team. The work that we do is vital, and your data shows that perfectly, and it affirms how we're able to come into that space where we bring that non-anxious presence, and we are able to facilitate peace in the room because hopefully we bring the divine with us, and we're able to help individuals connect with what gives them meaning and what gives them hope, what gives them purpose, what gives them joy, what gives them wonder. That is how do you measure that? Well, you have data that speaks to what happens when those things don't occur. And so this is why we love partnering with individuals like you and agencies like yours, because it helps us to connect what we do in the spiritual well-being realm with what helps drive information, actionable information. So thank you for affirming our work. I will tell you that I remember when I entered a room years ago, and one of my earliest experiences as a chaplain in the oncology setting was that the patient was at end of life, palliative. And I walked into the room, it was on Christmas Day, and the patient said, I introduced myself thinking they would be happy to receive a candy cane. And the patient said something to the effect of, give me one reason why I should live. Give me a reason why I should continue to live. And from there, for the next couple of weeks, we were able to just kind of journey with him and partner with him on what was important to him, what gave him joy, meaning, hope, purpose. But he was the one in control. And when we say that he had he was able to, I don't want to say control, but he was able to frame how he wanted his end of life to be. And that's exactly what we were able to carry out. I will tell you that when it comes to research that affirms experience with a patient who was DNR and DNI, do not resuscitate, do not intubate, that call came after the patient came into the ED. He's rushed in by an ambulance. The physicians, and he's having a lot of difficulty breathing. And so the physicians indicated that intubating him was not going to help. This cancer patient was going to die. Somehow we were able to connect with the fact that, let me back up. With faith and African Americans, the church is a cornerstone, both literally and figuratively. And I think that's why religion is very much important, and it plays a very much important role with our African American patients. But in this patient's case, that was exactly the truth of the matter. And we were able to we started singing hymns, old-fashioned hymns from back when I sat on that Baptist pew back in Tulsa, Oklahoma. And we sang hymns, and that's how we were able to connect with him and his spiritual well-being. And believe it or not, who knew at the time, but the hymns were able to help him regulate his breathing. So while he could, he actually started singing with us, and that's how we were able to help him connect with what gave him hope, meaning, life, purpose, and joy. So it was the singing of the hymns that did that. Again, DNI, DNR, But and so because the clinical team did not intubate him, and he was not did not resuscitate him, we were able to sing him into heaven. How about that? I'll tell you that in the outpatient side, this is where I think we can really make a huge difference. Outpatient on the clinical side had just received the cancer diagnosis, young patient, and professional patient, healthcare worker, and was not expecting this diagnosis, had just gotten a new job, young children, married, and had received this cancer diagnosis. And what we were able to do was just start the theodicy conversation from the very beginning. Why is this happening to me? And every chaplain who's listening has had that conversation one time or another with their patients, and particularly patients at end of life, and particularly with cancer patients when a patient receives that cancer diagnosis. And so we were able to just start delving into their theology, what they believed, and then the theodicy question: why is this happening to me? Why would this occur? Why would God allow this to happen to me? And we were able to help that patient get to a level of peacefulness and acceptance. Again, this was a healthcare professional, but still was in grief-stricken and just denial about the cancer diagnosis. But with that, just spending that spiritual time and working through theodicy, we were able to help that patient reconnect with what gave life and meaning and purpose. And then I'll tell you one of the most transformative patient visits I had was with regard to getting and connecting with that cancer outpatient on the front end. When this patient had just walked from the doctor's office, had just gotten that prognosis that you may have months to live. We were able to sit down and we started talking about their faith, what was important to them, what gave them joy, meaning, hope, and purpose. By the way, I think it's the Institute of Healthcare Improvement that has a wonderful series on question about what matters most. And when you engage the patient with what matters most, you're really able to get the ball down the field. And that's my only football analogy. I don't know sports. Then there's the Christian comedian Michael Jr. If anyone can Google this, he has a YouTube video. It's only about 3 or 4 minutes. But Michael Jr. asked the question of, what's your why? What's your why? Google that thing, look at it. And that's kind of the approach I use with this particular outpatient. Again, had just received a prognosis, had life, before them, but no longer with this prognosis. So after we spent a couple of weeks working through the grief, one of the things we implemented was, what's your why? What gives you hope, meaning, and purpose? What matters to you most? And what he wanted to do was die on his terms. So he started, he had a party, and people from all over the country, places where he lived previously, they would send him his favorite food from that location, whether it was hot dogs from Austin, I think it was barbecue from Austin and hot dogs from New York, but and then seafood from Maryland. But they were able to send that stuff to him. He had spent 2 weeks just really celebrating food and the joy of friendship, and how friends just collaborated with him in that. And that's how we were able to get him to a point where he was accepting of the prognosis. He was accepting of his leaving us, and there was a peacefulness about him that you just, I don't even know how you measure it, but there was a peacefulness that came because of that spiritual connection that we had with him. So my response is this, Holly, that you've affirmed a lot what I've believed and thought to be true. Your data supports that. And I'll tell you that as chaplains, as we continue to try to show relevancy and how we impact outcomes, I think this project this research that you've done helps us in our work on this side of spiritual care.
Well, to your point about the healthcare chaplaincy and healthcare costs and relevance to hospital administrators, and who might question, do we want to support a healthcare chaplain or a hospital chaplain? I didn't present this because it always seemed a little crass to put a dollar figure on it, but we've published it, and I had presented it to New York Presby Hospital chaplains, and they're like, this is what they want to show their administrators, is that we showed very, very significant cost reductions in the end of life if the patient had met with a healthcare chaplain versus not, which is totally understandable because most of the expense of end of life hospice care is associated with is pretty cheap. You know, honestly, it's not the per diems that Medicare has to pay for a hospice are extremely less than an ICU stay, which is, well, there used to be stats that 40% of the Medicare budget was spent on the last year of life, and 25% of that was like in the last month of life, mostly because those costs are attributed to intensive care. And to the extent that a chaplain can keep people out of the intensive care unit for all the reasons that you just mentioned, is exactly why you would expect to see the value added and the cost saved of integrating chaplaincy into a hospital system. It's going to help the payer. Medicare would save billions of dollars if healthcare chaplains were integrated. And I don't like to present that because it just seems so crude, but to your point, that's a justification for why should healthcare chaplains be integrated into care. That's it right there. There is a dollar figure to assign to that. Yeah.
Thank you. Paul?
Thank you, Carla. Oh, and I'm curious, Holly, did you have any other insights or thoughts or any other response in addition to anything Carla kindly offered in response to your talk?
Well, I definitely think that her point about having the data to support not only what you do, why it works, why it's helpful, how it's helpful, but also even in terms of crude dollar and cents, is it worth it for hospitals to appreciate and integrate a healthcare chaplaincy? The answer based on our data are yes. So that's one of the reasons why we think it's just hugely important. It's one of the rare situations where it's a win-win. It's a win. It's not, you know, in this sense, like less aggressive care, more chaplaincy care is a cost savings, and also their spiritual care needs are met, burdensome care is avoided, family members are better adjusted. So I really, and maybe it could reduce medical mistrust and potentially racial disparities in the quality of care patients receive. If it could do any one of those things, that's huge. Just in terms of suffering averted, it's so I always acknowledge that I'm not a very religious person, and people say, well, why are you, like, of all people, why are you studying this? Because I follow the data, and you know, I know a winner when I see it, and it seems like there's just so much potential with chaplaincy that why has this been overlooked? And we're hoping that if we do the study right, we'll have the evidence to explain it and to demonstrate it. So.
Thank you. And Carla, again, I just want to say a little more thorough thanks. Because I was just be curious before I turn it over to a Q&A here. I definitely have a question or two. For your wisdom, your insights, practically applied and in response to Holly. I just do have to also say this close to lunch where I'm getting this thing when you talk about Austin barbecue. You're killing me. You're taking me back to Chewy here for a second. So, all right. So, but Carl, anything else too that you want to add, you know, after Holly offered a few more thoughts before I turn it over to an official question here?
No, go ahead, Paul. Thank you.
No, thank you. So here's a question. Do you think the race of the chaplain will make a difference in the effect of the chaplain on end-of-life care for racial minority patients?
Is that to me?
Yeah, I'll start with you, Holly. That'd be great. And then I'd be curious if Carly, you have any thoughts? But yeah, certainly from all the data you know, and your curiosity, yeah, I'd love to hear you respond.
Well, to me, the answer is obviously yes. However, we have a study of Latino disparities and therapeutic alliance between Latino oncologists. and their Latino and non-Latino patients. And we were sort of shocked to find that the Latino patients had worse bonding and therapeutic alliance with their Latino doctors. So I don't know whether, they feel like the Latino oncologists are not, they've sold out, or they're just in a different, they're not like them, or can't trust. I don't know what's going on there. We haven't really unpacked any of that, but that sort of jarred us in terms of, because I think it seems almost too obvious to think that you would trust someone with whom you identify, and the sense, if you're a woman, you want to see a woman gynecologist, and if you're an old person, you don't want a kid treating your sciatica, and so, I mean, it makes sense that you would feel that the sort of racial matching would enhance the therapeutic bonding, even though we are finding counterintuitive results with the Latino patients. What we did find was that patients who speak Spanish have better therapeutic alliances with all their patients. So maybe that's an indication of sort of an openness on the part of the oncologist. But to your question, one issue seems to be with oncologists, when we've tried to study these things, we've said, would racial matching of the oncologist, like a Black oncologist with Black patient, result in different outcomes? And the problem with all those studies has been that there just isn't, we can't study it. There aren't enough Black oncologists, so that's, we've got to work with the reality of the healthcare system and try to improve therapeutic bonds among most likely mismatched racial groupings between a white oncologist, or usually, often many Asian oncologists, and Black and Latino patients, just because the staffing distribution is different. But that's not the case for healthcare chaplains. So for our proposal, we propose to examine exactly that issue, Paul. So we do matching. So, I mean, there are plenty of Black chaplains. And would a Black patient prefer to meet with a Black chaplain? Yeah. Would a white patient prefer to meet with a white chaplain? Yeah, maybe. I don't know for sure. But I would. So I'll stop. Those are my 2 cents. So
Thank you. I appreciate that. Carla, any thoughts on that before I transition to another question?
Just my thoughts are, it maybe a African American patient would affiliate closer with an African American chaplain. It just kind of depends. But I will say that in the places where I've worked, it's been so collegial that if we find that we think another chaplain might be able to connect with that patient, we'll just refer, and so we're able to resolve that issue.
Okay,
well,
I appreciate
that does bring a question of whether race would trump, for example, faith. Like if so say you have a Catholic Black chaplain versus I guess, is it more that they're from your faith, or just or like a rabbi? What it doesn't matter, is race more important than the belief system?
What I found with my end-of-life patients is it doesn't matter. That when they're at end of life, we get to have the real conversations, and race is not a factor, gender is not a factor, even faith tradition is not a factor. They want someone who can connect with them and help them with what gives them hope, meaning, and purpose. So that's been my experience.
I hope the data show it. That would be great. I fear that we're getting close to time. I want to say to all of you who have been able to join and stay on with us, thank you for your participation with us today. If you are not yet a part of the Hospice Palliative Spiritual Care Research Network, please consider joining us. You'll be sent a link with this presentation, and we'd love to have you be part of us. You do not need to be a researcher, just somebody who cares about the evidence base as it informs your work. But if you are a researcher, we'd love to have you among us too. Please also check out Transforming Chaplaincy's YouTube channel. We have past webinars posted there. We'd love to have you be a part of that. We are at noon. So to you, Reverend Price, to you, Dr. Pregerson, magnanimous kinds of thanks and oodles of gratitude for your investment into this time, for our work together, and look forward to seeing what this research bears out in time.
Thank you for the opportunity.
All right. Thanks, everybody.
Thanks, everybody.
Have a great afternoon.
All right.